Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. We are about to embark on a deep dive into the world of kidney transplantation, specifically from our perspective as anesthesiologists. It's a fascinating and complex journey, and we're going to cover it all.
So, here's our game plan. We're going to follow the patient's path, step by step. We'll start with the absolutely critical preoperative workup, then walk through the surgery itself, our core anesthetic management, and on into recovery and some of the more unique transplant situations you might encounter. We'll wrap it all up by looking at how the ERAS protocol ties everything together. This isn't just theory, it's designed to be a practical guide for your clinical practice.
All right, let's kick things off with Section 1, the foundations. Success in the operating room for these patients is almost always decided before the patient even gets there. Meticulous preparation is everything.
Now, the very first thing we have to get our heads around is that end-stage renal disease is not just a kidney problem. It is a systemic, multi-organ disease. This table really drives that point home. Just look at the cardiovascular column. These patients often have hypertension, LVH, CAD. They are primed for hemodynamic instability. Then you've got anemia and platelet dysfunction, which means you're worried about both oxygen delivery and bleeding risk. And of course, the metabolic chaos of hyperkalemia and acidosis puts them at huge risk for arrhythmias. And we can't forget gastroparesis, a classic aspiration risk. So every single system on this chart is waving a red flag at us that we have to address preoperatively.
Okay, so how do we dig into that cardiovascular risk? Well, this is our essential toolkit. An ECG is our baseline, of course, but the 2D echo, that's our crystal ball. It gives us a direct look at left ventricular function, it shows us valvular disease, it helps us estimate pulmonary pressures. Identifying a patient with a really low ejection fraction or severe pulmonary hypertension before we go to the OR is absolutely non-negotiable. These are the patients who will not tolerate the major fluid shifts and hemodynamic swings of this surgery without very, very careful management. So let's talk about fixing some of these problems. These are the big three we have to wrestle into submission: hyperkalemia, acidosis, and anemia. Dialysis is our best friend for the first two. But look at anemia. This is where it gets tricky. Of course, we want to improve their oxygen carrying capacity, but we have to be so careful with blood transfusions. Why? Because every unit of blood is a foreign substance, and it can introduce new human leukocyte antigens, or HLAs. This can sensitize the patient's immune system, basically training it to attack foreign tissue, which could lead to a rejection of their future kidney. It's this incredible balancing act between immediate needs and long-term graft survival.
And that leads us perfectly into the modern concept of prehabilitation, which is a core part of enhanced recovery after surgery protocols. This is a real paradigm shift. We're moving away from the old model of just clearing a patient for surgery. Instead, we're proactively trying to make them a better surgical candidate. Think of it like a training camp for surgery. We're optimizing their nutrition, building up their physical reserves. We are actively preparing their body to withstand the immense stress of the operation, and in doing so, speeding up their recovery on the other side. It's a total game changer.
Okay, with that solid foundation laid, let's move into the operating room and talk about the surgical timeline, starting with where this life-saving organ actually comes from.
It's so important to remember that not all kidneys are created equal. The source of the graft profoundly impacts our anesthetic management. A kidney from a young, healthy living donor is going to have minimal ischemia time and is likely to start working immediately. That's a completely different scenario than a kidney from an expanded criteria donor, or ECD, which might have a longer ischemia time and a higher risk of delayed graft function. Knowing the donor and the graft's KDPI score helps us anticipate potential problems and tailor our plan accordingly.
So once the kidney is procured, how do we keep it safe and sound until it's implanted? We've got two main techniques. On the left is static cold storage, which is basically a specialized cooler. It works great for grafts with short ischemia times. But on the right, we have hypothermic machine perfusion, or HMP. This is really cool technology. It's not just a cooler, it's an active life support system for the kidney, continuously pumping a cold oxygenated fluid through it. This not only reduces injury, but can actually give the surgeons valuable data about the kidney's viability before they even put it in.
I absolutely love this slide because of how practical it is. In a long, complex, high-stakes surgery like a kidney transplant, it is so easy for crucial details to fall through the cracks. This checklist isn't just a to-do list, it's a cognitive safety net. It forces communication at critical junctures. It makes sure that everyone, surgery, anesthesia, nursing, is on the exact same page about the final cross-match results, the donor status, and especially the timing of those critical immunosuppression drugs. It's an essential tool for patient safety.
And that brings us to the heart of the matter. Section 3,
our core intraoperative anesthetic management. This is where precision, vigilance, and a deep understanding of physiology really shine.
Okay, if there's one slide to really commit to memory, it's this one. This is our pharmacologic playbook. The single guiding principle is this: choose drugs that are not dependent on renal excretion. The classic example, and one we must get right, is with opioids. We almost exclusively use agents like fentanyl or remifentanil. Why do we avoid morphine? Because morphine is broken down into active metabolites, which are then cleared by the kidneys. In a patient with no kidney function, these metabolites accumulate and can cause profound and prolonged respiratory depression long after the surgery is over. It is a fundamental safety choice.
And this brings me to a concept that should be music to every anesthesiologist's ears: Hoffman elimination. This is our get-out-of-jail-free card. When you give a neuromuscular blocker like cisatracurium, its breakdown is not dependent on the liver or the kidneys. It literally self-destructs in the bloodstream based on the body's own temperature and pH. This gives us an incredibly predictable and reliable duration of action, no matter how sick the patient's organs are. It's elegance and safety all rolled into one.
So, all of our planning, all of our careful drug choices, all of our preparation, it all builds to this single defining event in the operating room: the reperfusion of the new kidney.
As those vascular clamps come off, our mission is crystal clear, as outlined on this slide. We have one primary goal: perfuse that new kidney. Here's the key physiology you have to remember. This newly plumbed-in kidney is denervated. Its nerves have been cut. It has completely lost its ability to auto-regulate its own blood flow. It is 100% at the mercy of the systemic blood pressure that we provide. That's why we target a higher MAP, often between 90 and 110. We use dynamic parameters like pulse pressure variation to ensure the patient is euvolemic, not too dry, not too wet, and then we carefully titrate vasopressors to hit that pressure target. That first drop of urine is the most beautiful sight in the OR.
All right, the kidney is in, the case is finished, but our job is far from over. Let's talk about the transition to recovery with a special focus on modern, effective pain management.
This quote perfectly captures the current philosophy. We've moved away from just blasting patients with opioids. The goal now is multimodal analgesia. This means we're using a combination of different medications and techniques that attack pain from multiple angles. And the reason is simple. By using less opioids, we see less sedation, less nausea and vomiting, and less postoperative ileus. That means our patients are feeling better, moving sooner, and ultimately recovering faster.
So what's in our multimodal toolbox? A couple of things on this table are absolutely critical to point out. First, look at the non-opioid section. You see in bold, NSAIDs are contraindicated. This is a never event. Drugs like ketorolac can be nephrotoxic and can injure this precious new graft. They are completely off limits. Second, look at the top line: regional anesthesia. Facial plane blocks, like the TAP block, have become a cornerstone of our practice. They provide amazing, targeted pain relief for the surgical incision without the risk of hypotension you can get from an epidural and without the systemic side effects of opioids.
And if you need proof that these blocks work, look no further. This is data from a powerful meta-analysis published in 2025. These are called forest plots, and they combine the results from multiple studies. All you need to do is look at the plot on the right and find that black diamond at the bottom. See how it's well to the left of that vertical line? That vertical line represents no effect. The fact that the diamond is so far to the left tells us, with high statistical confidence, that TAP blocks significantly reduce opioid consumption.
And here's the bottom line, the take-home number. On average, patients who received a TAP block required over 14 milligrams less morphine in the first 24 hours. Now, that is not just a statistically significant number, that is a clinically massive difference. That's the difference between a patient who is comfortable, awake, and participating in their recovery, and one who might be overly sedated, nauseous, and in pain.
Of course, not every transplant is straightforward. Let's quickly touch on a few special populations that throw some interesting curveballs our way and require us to adapt our plan. ABO-incompatible transplants are a fascinating feat of modern medicine, but for us, they present a unique set of challenges. To make the transplant possible, these patients undergo preoperative plasmapheresis to remove the antibodies that would attack the new kidney. But here's the catch. That process also removes their clotting factors and albumin, so they arrive in our OR in a state of induced coagulopathy. This means we have to be absolutely hypervigilant about bleeding, very cautious with any regional anesthesia techniques, and often need to administer albumin to maintain oncotic pressure and hemodynamic stability.
All right, for our final section, let's zoom out. We've talked about a lot of individual components,
Now let's see how they all fit together under one comprehensive framework, the ERAS, or Enhanced Recovery After Surgery Protocol.
This timeline really illustrates the beauty of ERAS. It's not one single magic bullet. It is a philosophy of care, an integrated pathway that connects every phase of the patient's journey. It starts weeks before surgery with prehabilitation. It continues in the OR with our goal-directed fluid therapy and opioid-sparing analgesia. And it extends into the postoperative period with early mobilization and nutrition. Every single element we've discussed today is a critical link in this chain, and when they all work together, the result is a dramatically improved patient recovery and a shorter hospital stay.
And so that leaves us with a final, thought-provoking question. As we get better and better at getting patients through the immediate postoperative period safely, the next frontier is emerging. Is our role simply about short-term survival, or are the choices we make, the pressures we run, the fluids we give, the drugs we choose, actually influencing the long-term health and function of that graft, years and even decades down the road? That, I believe, is the question that will drive innovation in our field for years to come. Thank you so much for joining me for this deep dive today.